Thanks. Thanks for the invitation. Just going to move this up here. And so I'm happy to talk about interstitial lung disease and specifically ILD in the context of anti-neoplastic treatments. Certainly something that I get asked to see a fair bit here at Sunnybrook and elsewhere. So I'm certainly happy to discuss it with the oncology group. And, you know, in anticipation of the sort of ongoing growing list of cancer treatments, it's something that we're constantly having to keep up with and learn more about. So a bit of disclosure. So I have received grant funding from U of T, from the Canadian Pulmonary Fibrosis Foundation, and from the hospital, as well as have accepted speaking honorarium. Another disclosure, obviously I'm not an oncologist, and it's always a bit strange to be speaking about things that I don't prescribe. But it's certainly we get asked to see frequently for complications. So, you know, if I'm talking about certain cancer treatments, it's very possible that, you know, and likely that you're going to know more about some of the practical aspects of those treatments than I do. And so I apologize if I misspeak about how some of these cancer treatments are used in the context of certain malignancies, because they're not things that I generally prescribe. Some of the learning objectives, just to provide an approach to interstitial lung disease and with respect to the diagnosis and classification. I'll talk a bit about specific anti-neoplastic agents and how they cause ILD, discuss an approach to ILD in cancer patients, and review some of the data for monitoring and treatment. So I'm going to start off with a case of a 65-year-old woman that I follow with ILD, who was initially referred with cough and shortness of breath. Her CT scan showed new pulmonary infiltrates. She had a known history of metastatic breast cancer, HER2 positive, with known mets to lung and liver, and at that time was being treated with paclitaxel, pertuzumab, and trastuzumab. She was only on Synthroid for her hypothyroidism, was an ex-smoker, worked in an office setting without any significant exposures. She did have a family history of connective tissue disease in her mother, and she was referred after 4 to 6 weeks of shortness of breath and cough, no infectious symptoms. She had had some lower extremity swelling, which was long-standing, and did report some joint discomfort as well on review of systems. On examination, her resting saturations were okay, 94%. She did have inspiratory crackles on auscultation and some noted joint swelling and trace edema. She had had some screening blood work for autoimmune disease performed, which showed an isolated elevation in anti-SSA antibodies, but otherwise normal ANA, rheumatoid factor, CCP, ANCA. Her initial pulmonary function testing showed parenchymal restriction, which is what we define as when the lung volumes are reduced, so low vital capacity and low total lung capacity. And so when we see a low total lung capacity, it's suggestive of restriction. And then when the diffusing capacity is also reduced, we would call it parenchymal restriction, as it suggests that there's a problem with the lung tissue itself, as opposed to when the lung volumes are normal, but when the lung volumes are reduced, but the diffusion is normal, that would be suggestive of extra parenchymal restriction, possibly related to diaphragm weakness, obesity, or kyphoscoliosis or neuromuscular disease. And here are a few select cuts of her CT scan, which show some increased opacification. I didn't show any upper cuts, but it was more predominant in the lower lung zones. You get the sense that there's almost some sparing of the periphery aspect of the lung here, and it's involving more peribronchial vascular distribution, so around the airways and sort of more central part of the lungs. And so this was reported by the radiologists to be compatible with organizing pneumonia, and they labeled these features as consistent with interstitial lung disease. And then she was referred to respirology for a question of could she have drug-related lung toxicity. And so just stepping back a bit in a review of some of the terminology, because it is a bit confusing and a lot of the terms do get sort of used incorrectly And I feel it's taken a long time for me to even kind of become accustomed with all of these terms and how they're used. And I think in general, interstitial lung disease, diffuse parenchymal lung disease, and pulmonary fibrosis are often used interchangeably. But it's important to remember that these are not synonymous with idiopathic pulmonary fibrosis, which is a subtype of interstitial lung disease. And interstitial lung disease, as the name suggests, are diseases that involve the interstitium, which is this space between the alveoli and the capillary. And so when there is thickening or scarring of the interstitium, over time, that can lead to lung restriction, reduced lung volumes, inability for oxygen to diffuse into the capillary, and then patients will experience progressive shortness of breath, hypoxemia, and ultimately respiratory failure. And the American Thoracic Society has provided a framework for ILD, or diffuse parenchymal lung disease, for many years, and not much has changed. They grouped them into broad categories of interstitial lung diseases of known causes, including drugs like chemotherapies, connective tissue disease, the idiopathic interstitial pneumonias, of which IPF is the most common form. These are a group of chronic progressive scarring lung diseases, smoking-related lung diseases, and other rare idiopathic interstitial lung diseases that get lumped together because they can be idiopathic. There's granulomatous diseases such as sarcoidosis, and then a few sort of rare conditions that are also included in this framework. And it's a bit of a misnomer to include all of these under the realm of interstitial lung disease, because unlike IPF, which is really a disease that's restricted to the interstitium, I'm showing a CT scan of one of my patients here where you can see that there's increased what we call reticulation, or these increased lines. There is traction bronchiectasis, these dilated airways with neighboring diseased lung, and these sort of cystic lucencies or honeycomb change. The predominant anatomic abnormality is isolated to the interstitium, whereas this CT scan highlights a patient with interstitial lung disease related to gemcitabine toxicity, which you can see the CT scans look very different. Here there's sort of diffuse opacity, ground glass, and consolidation. The process is likely one involving the alveoli as well as the interstitium, but yet it gets included in this framework of interstitial lung diseases. And other conditions in this framework may be even airway centric, but because they can involve the interstitium, they get grouped into this framework. And the ATS has published guidelines on how to diagnose and evaluate patients with IPF. And I realize this is a bit sort of far off from seeing patients with, anti-neoplastic related ILD, but I think it's important to review these guidelines in brief, because the approach to interstitial lung disease in general is really the approach to IPF. Because by definition, if you can diagnose IPF, you've excluded everything else. And so this is the framework that I still apply to all the consults that I get from the oncology service when being asked to evaluate for patients with suspected drug-induced interstitial lung disease. And it starts with sort of going back to the basics and taking a detailed history and physical and reviewing their medication list for pneumotoxic exposures, taking an occupational history to look for inorganic exposures such as asbestos, silica, coal, beryllium, and other things, reviewing for environmental exposures, organic exposures such as bird feathers or mold being common culprits here, and also screening for connective tissue disease, specifically looking for any abnormal ANA, ENA, rheumatoid factor, and CCP. And these are recommended for all patients as screening tests because connective tissue disease is so common in patients with interstitial lung disease. And after this, we review the CT imaging carefully because it really has become a central part of how we investigate and categorize patients with interstitial lung disease. And the ATS recommends breaking down the imaging pattern into one of 4 criteria. And you may have seen some of this terminology used in CT scan reports for your patients. And it's suggested that they be categorized as a UIP, or usual interstitial pneumonia pattern, a probable UIP, indeterminate for UIP, or pattern suggestive of an alternative diagnosis to UIP or alternative to IPF. And it seems a bit semantic, but it's actually quite important because it changes the way we think about diagnostic sort of probability with certain conditions and how we should go about excluding other conditions. So just briefly touching on the criteria for these categories, the case that I presented earlier with my patient with IPF, here I'm showing the images again, and they show a typical UIP pattern where there is a basilar predominance, so more disease in the lower lung zones. There is reticulation, these increased sort of interstitial lines with honeycomb change, these cystic lucencies that are involving the subpleural area, so around the outer lining of the lung. And so these features would confirm that this is a UIP pattern. The probable UIP pattern is just like UIP, but there's no definite honeycombing, which is highlighted here. So this increased reticulation, some traction bronchiectasis, the airways are dilated compared to the neighboring blood vessel, but no honeycombing. The indeterminate pattern is the most challenging category. This often reflects cases where there's mild disease, and so it's hard to categorize, or cases where there are inconspicuous features that may point away from a diagnosis of IPF. And some of those features are highlighted in the alternative diagnosis category. And these would include cases where there's sort of a lot of central lobular cysts, so not honeycomb cysts, but these sort of cystic lesions within the parenchyma themselves, whether there's ground glass opacity, this increased attenuation of the lung tissue, but with preservation of the background architecture, you can still see blood vessels and lymphatics, but the intensity is above what you would expect for normal lung. That would constitute ground glass. Whether there's mosaicism, this patchiness to the parenchyma, diffuse micronodules as highlighted here, dense consolidation, where there's complete opacification of the background architecture, or cases where there's an upper lung zone predominance or peribronchovascular predominance, where there's disease more around the perilymphatics and hilum. And the reason these are chosen is because these features are all more commonly seen in other diseases than IPF. And the reason why it's important is because if people have a UIP pattern on imaging, it is highly predictive of having a UIP pattern on biopsy with a positive predictive value of greater than 90%. So this is important to determine whether a surgical lung biopsy or other tissue biopsy is worth pursuing, because the imaging can be quite telling. Now, for patients with indeterminate or alternative category diagnoses where they're thought to have idiopathic ILD, in those cases, we may consider a bronchoscopy for certain conditions, or we'll consider doing a surgical lung biopsy. And after that's done, we'll review the results in what we call a multidisciplinary discussion, kind of like tumor boards, where we all get in a room and we try to determine what that patient has based on the clinical presentation, imaging, and biopsy results. And so going back to the case that I presented of our patient with breast cancer, looking at their CT scan, well, there's certainly increased ground glass opacity. There's areas of dense consolidation where we lose the background architecture of the lung. There's traction bronchiectasis, suggesting that there is fibrosis and architectural distortion, and it tends to be more of a peribronchovascular distribution. So this is not a UIP pattern. This is a pattern suggestive of a non-IPF diagnosis. And in this case, it's sensible to consider drug toxicity because it can present with patterns that look like an alternative pattern to IPF. And so when we think about interstitial lung disease in the context of patients on anti-neoplastic medication, it's difficult to keep up. This figure is very small, but it's done intentionally because there are dozens and dozens of anti-neoplastic medications that have been linked to cause pneumotoxicity. And chemotherapies are actually the most common class of medications attributed to causing interstitial lung disease. And each drug has a unique sort of profile, risk, presentation, timing, and it can be really challenging to keep up, especially at the rate that new chemotherapies and treatments are coming out. Back in 2020, Health Canada approved 17 anti-neoplastic medications or immunomodulatory medications, more than any other group of drugs. So it really is a quickly evolving field. And yet as a respirologist, I'm expected to know about these drugs, yet I never prescribe them. So it is quite challenging. And so when I'm referred these sorts of patients, my general approach is to first review the medications that they're on and try to have a risk assessment. And one thing that I feel is somewhat helpful for that, and some of my colleagues do as well, is utilizing some of the resources, specifically something called Pneumotox. I'm not sure if people are aware of this resource. It's an online sort of repository and an app that you can download on your phone where you can search for the rate of lung toxicity from medications, and hundreds of medications are included, and they sort of break them down into different risk profiles. You can search by medication or by pattern of disease, and here they have different sort of numbers attributed to each medication, which correspond to the number of case reports in the literature, just to give you a sense as to how frequent certain lung toxicity is reported. And then you can click on the medication and actually see subtypes of lung toxicity, airways disease, and then even, cardiotoxicity and other sort of intrathoracic toxicities. And each one is attributed based on the number of case reports. So for drugs that I'm maybe less familiar with, this is a helpful sort of first step to get a sense as to the risk profile. And then I'll review the details of the case. What was the patient receiving? How long were they receiving it? And try to get a sense as to the timing of this. And, each medication is slightly different, but certain drugs in higher doses are more prone to develop or cause lung toxicity. This is a table, our forest plot, just highlighting the risk with trastuzumab deruxtecan, suggesting that higher doses may increase the risk of ILD. And it's not unique to this medication, but certainly in other anti-neoplastic medications that can also be the case. I also try to take a detailed history to look for concurrent treatments, other combination chemotherapies, concurrent radiation, and the timing of that radiation. Certainly, there are certain medications that are linked to radiation recall reactions where patients may have had thoracic radiation many months ago, yet it can lead to an increased inflammatory reaction within the radiation field. So I'll sometimes even email the radiation oncologist asking for the planning scans to see if this sort of anatomically correlates to where they're experiencing changes on their CT. And then we have to take a real detailed history, because the devil is in the details with these patients. They're complex patients with lots of comorbidities. And even when we highly suspect interstitial lung disease from medications, it can look very similar to infection, edema, disease progression, hemorrhage. And so, we still need to ask about fever, sputum, look at the white count, review for COVID-19 exposures and test for this, do a volume status assessment, evaluate whether there's evidence of disease progression elsewhere on their imaging, look for hemorrhage with hemoptysis, coagulopathy, or other signs of toxicity like rashes, transaminitis, eosinophilia on the blood work. There are sort of routine screening investigations suggested by review articles related to anti-neoplastic drug toxicities. I mean, most of them are pretty standard. I disagree with several of them because they're not available or practical or evidence-based, particularly things like procalcitonin, certain alveolar markers of interstitial lung disease. And we don't really have access to these or use them frequently in Canada, or at least not in Toronto. I will say that a BNP can sometimes be helpful to exclude signs of heart failure. Many of these drugs will have concurrent cardiotoxicity. In this day and age, patients should be screened and swabbed for COVID-19. Often for our hematologic malignancy patients considering CMV and other sort of signs of worsening disease. And I've already sort of thoroughly gone through the different categories of ILD imaging, but we really take a detailed look at the scans, because the scans can often give other suggestions of certain imaging patterns and suspicion of drug toxicity, which generally tends to be more bilateral than unilateral, though sometimes you can be fooled. But some of the most common patterns related to drug-related ILD, I'm going to go through here. So the first would be organizing pneumonia, which is the most common pattern that we see related to drug-induced lung injury. Features of this would include ground glass and consolidation, usually a lower lung zone predominance. They can have more sort of telling features, what we call halo sign, where you'll get these sort of rings of consolidation with ground glass in the middle. And when you see that, it can be quite suspicious for drug toxicity. It's not completely specific. It can also be seen in vasculitis and fungal infections, but certainly in the right clinical context would be concerning for drug-induced organizing pneumonia. Acute interstitial pneumonia is the most concerning pattern of drug-related lung injury. These are patients that often present with fulminant respiratory failure and end up in the ICU intubated. The pattern is one that looks just like ARDS, or acute respiratory distress syndrome, with bilateral opacities, dense consolidation, and traction bronchiectasis, suggesting the development of architectural distortion. Eosinophilic pneumonias can occur from anti-neoplastic treatments. The pattern is similar in that there's bilateral ground glass and consolidation. Some of the unique features are that it often tends to be more peripheral, so sparing the sort of central aspects of the chest. It tends to be more mid and upper lung zone predominance. So when you see that, it can really sort of point towards eosinophilic pneumonia. Hypersensitivity pneumonitis is a form of lung inflammation where we'll see granulomatous disease on biopsy. The imaging pattern, which can occur with drug toxicity, is shown here, where you'll get these centrilobular ground glass nodules. You get the sense that these rounded inflammatory nodules often tends to involve more of the hilum and peribronchiovascular areas, and also mid and upper lung zone predominance. So when you look at a scan like this, it can suggest an HP pattern and certainly can be related to drug toxicity. And the last form or pattern to mention is one called non-specific interstitial pneumonia, or NSIP. This is a pattern of ILD that it tends to involve the lower lung zones more. There's ground glass and traction bronchiectasis. One of the unique features is shown here, this sort of subpleural sparing. You get the sense that this sort of neighboring area around the outside of the lung is not involved. And when you see that, it can be quite telling for NSIP. And so there have been sort of published suggestions on how to approach patients with suspected drug-related ILD. This one is for trastuzumab deruxtecan. And you know, they suggest consulting a pulmonology or respiratory medicine early on when it's suspected. I think primarily for, you know, a second opinion, and also for consideration of bronchoscopy. And so I wanted to talk just a bit about the value of bronchoscopy in interstitial lung disease. And there are guidelines that have been published by the ATS. And I will say that overall, I think bronchoscopy has a limited role in ILD evaluation for fibrotic lung diseases. So we don't generally do bronchoscopy for IPF or other very fibrotic patterns, because it's really unlikely to show any results that are going to change our suspicion. The main, I think, reason to do it in our oncology patients are because the imaging can be suggestive of infection as well. And so excluding bacteria, fungus, especially if they're immunocompromised, doing galactomannan testing to look for aspergillus, pneumocystis, either by PCR or cytology, especially if patients are on concurrent steroids. And again, consideration of COVID-19. I've had a number of referrals in the past 6 months for, you know, is this drug-related toxicity? Their NP swabs are negative. We do a bronch and it's COVID-19. And it's been there for 6 to 8 weeks because they're immunocompromised and still shedding virus. And so I've had a number of cases like that. I will just say for your knowledge that when we're consulted, we generally don't do bronchoscopy in patients on 50% FiO2 or more, just because of the risk of respiratory failure, or for those that are really showing an increased work of breathing because of the associated risks. The other aspect of bronchoscopy that can be helpful is performing a cell count. And so this is where we'll do a washing of the alveoli and send it for certain cells to the hematology lab, specifically to look for signs of elevated lymphocytes and eosinophils. And so in the guidelines, they talk about lymphocytes greater than 15% or eosinophils greater than 1. In general, you know, anything above 20%, I think gets us, you know, 15 to 20% doesn't really get me too excited, but greater than 20%, and often the higher, the more suggestive it is. And same with eosinophilic sort of cell counts. And lymphocyte elevation can be seen in hypersensitivity pneumonitis, NSIP, organizing pneumonia. They've listed drug-induced pneumonitis, but as I mentioned, that can cause all of these patterns. So when patients are on drugs and they have elevated lymphocyte counts, it can be suggestive of inflammatory pneumonitis. And same with the eosinophilia, because it can cause eosinophilic pneumonias. Another aspect of bronchoscopy that's sometimes considered is the role for transbronchial biopsies. And this is where during the bronchoscopy, we'll actually put a little catheter out distally into the lung. We can't see the catheter. We sometimes use fluoroscopy to localize where we are, and we'll take random or targeted biopsies of the parenchyma. And this does increase the risk of bleeding in pneumothorax, though generally it's low, less than 5%. And this can be helpful in showing features of organizing pneumonia, granulomatous disease, specifically sarcoid and HP. And so we will do it occasionally when we're suspicious of those types of patterns. We can do it often to confirm malignancy, or more in our hematologic malignancy patients who are chronically neutropenic, to look for mucormycosis or miliary TB when the imaging is suggestive. I'd say for the majority of solid organ cancer patients, we don't do transbronchial biopsies because bronchoscopy is really to exclude infection most often, and the cell count can be supportive of drug-induced lung injury. And I think when we look at anti-neoplastic medications, certainly I feel like in the last few years, there have been a lot of review articles published on the rates and risks, specifically in breast cancer. And so I thought it might be worth just reviewing some of, or what seems to be some of the common chemotherapies that are used or going to be used in this population, and just to touch on some of the risks and risk factors. And one of these review articles kind of went through different sort of classes, and I think the first group to talk about would be the alkylating agents. And my understanding is that cyclophosphamide is something that's still used in breast cancer and is a rare cause of pneumonitis. The literature suggests less than 1%, though I have to say I actually got a consult today from dermatology for possible cyclo-related lung injury. It's been described both in early and late forms, though usually more often in early in disease course of treatment. And risk factors would include higher dose, concurrent radiation. It's kind of a bit paradoxical because, in connective tissue disease, cyclophosphamide has been shown to be helpful in scleroderma-related ILD. So certainly, we use it rarely to treat ILD, though it has these rare associations with causing lung toxicity. Some of the reports comment that certain regimens, specifically with FEC treatment, and certain doses of epirubicin were linked to increased rates of lung toxicity, though generally rare with doxorubicin. With respect to the antimicrotubules and antimetabolites groupings, I see patients prescribed taxanes for their breast cancer. Docetaxel and paclitaxel have both been linked to pneumotoxicity in a wide range of incidents, reporting from 1% up to 26% of patients. It's thought to be caused by hypersensitivity from cytotoxic T cells, and a number of risk factors have been reported, including underlying lung disease, specifically baseline ILD, concurrent chemo and radiation, and the presence of lung involvement from their breast cancer. Gemcitabine is less frequently reported, more often in non-small cell lung cancer populations. Interestingly, it's not thought to be sort of a dose-dependent or cumulative treatment response, as some of the systematic reviews have suggested it can occur around cycle 2, cycle 3. It has been noted to be a radiosensitizer, and cases of radiation recall have been reported. So always something that I consider when referred patients that are also being treated with gemcitabine and have had past radiation. I just highlight here systematic review talking about the cycle with which lung injury is seen and rates of mortality. I think methotrexate is probably the most interesting one historically. I think there's been a lot of concern about methotrexate causing lung injury over the past 2 to 3 decades, though there certainly is a shift in this thought in recent years. It's been linked to cause acute and subacute hypersensitivity pneumonitis. So if patients would have that pattern on imaging, if they were biopsied, it would show granulomatous inflammation. But whether or not it causes chronic progressive fibrotic disease is now falling out of favor, primarily because its treatment in rheumatic disease, it's hard to know, is it the disease or is it the drug? And more recent meta-analyses have suggested that methotrexate may actually be associated with reduced risk of progressive fibrotic lung disease. And so we're less likely now to attribute fibrotic lung disease to methotrexate, but certainly patients on methotrexate who experience fibrotic ILD, we want to stop the drug because it's certainly not preventing it from developing if they're getting worse. Interestingly, there has not been a large amount of case reports in pneumotoxicity in the breast cancer population. Now, I think some of the more recent drugs that I see used and are referred to me are some of these more targeted therapies and immunotherapies. And the first one that I've got here is the CDK4 and 6 inhibitors. I've had maybe 4 or 5 referrals for this over the past few months, patients on palbociclib. And in the literature, there's a range of pneumonitis, sort of 1 to 3.5%. Seems to be higher with certain medications, specifically abemaciclib in this one report. I think it's also, I'll just mention that the other toxicities linked to here have been noted to be cytopenias. And so when we're referred patients with nodular changes or ground glass changes, they may also be at risk for concurrent infection if they have lymphopenia, neutropenia. And so I think that's the main alternative consideration for patients with imaging abnormalities. This table comes from a study that was looking at reports of lung toxicity through the FDA reporting service across multiple trials. And they reported rates of ILD in the CDK4/6 molecules here. And although the numbers were generally low, the rates of hospitalization and death from lung toxicity were actually quite high, 50%, 30% when it occurs. And they sort of highlighted some sort of ranges in time to onset, which is somewhat helpful when you're seeing patients on specific medications. You can review the duration of exposure. Certainly in the past few years, immunotherapy has been a common referral to me in patients that have pulmonary infiltrates. Pembrolizumab is going to be the most common one that I see. The PD-1 have been sort of noted to cause lung toxicity more frequently than the PD-L1 targeted treatments. With respect to all grades of pneumonitis, PD-1 have been associated around 3.6%, slightly lower in PD-L1 at 1.3%. And thankfully, high grade pneumonitis, so hospitalized patients or critically ill patients, is generally low, but still something given the volume of treatment that is out there. We certainly see these cases and we evaluate them on the consult service every week, it seems, or at least every few weeks. And the pneumonitis is certainly a concerning side effect from these medications. It's one of the most commonly reported immunotherapy related side effects. And when you look at the fatality rate to the number of reported cases, the ratio is concerning, with sort of mortality ranges in here at least around sort of 10 to 15%. I will say that I often get asked to see patients who are starting on these drugs or on these medications with background lung disease, which is obviously a concern. I see lots of patients for background fibrotic lung disease. There was recently a meta-analysis published in CHEST, which confirmed that these patients are at increased risk of immunotherapy-related lung toxicity, both all grades and severe grades. This is just highlighting that any grade of pneumonitis in patients with background ILD was around 27%, and grade 3 or 4 pneumonitis in around 15%. So certainly much higher than the table I showed previously with rates in sort of the 1 to 3% range. The mTOR inhibitors, I'm not sure how often these are being used in breast cancer these days. I feel like I don't see a ton of referrals for patients on everolimus, though my understanding is it's been studied in the Bolero-2 trial and is associated with pneumonitis in sort of a 10 to 15% range, and there have been severe cases reported. Background lung disease is a concern. It seems to be slightly higher in non-breast cancer related disease, such as renal cell cancers where it's used. Interestingly, this was an observational study that was published a few years ago looking at patients with metastatic breast cancer who were treated with everolimus. They found sort of a clinically diagnosed rate of around 26% of having lung toxicity from treatment, more common in older patients. Although they found that patients that had evidence of lung toxicity, either on imaging or clinically diagnosed, seemed to have improved overall survival, suggesting that it may be a signal of efficacy from treatment. And the next class of medication is the sort of HER2 targeted therapy that I wanted to talk about. And the case I presented was a patient that had been receiving trastuzumab pertuzumab, which is really not sort of linked to lung toxicity commonly, less than 1% in the literature and in systematic reviews, though there have been cases in severe toxicities reported. It seems that bronchospasm or cardiotoxicity was a larger concern. Interestingly, the studies of combination therapy, the Cleopatra and Affinity trials did not suggest increased rates of lung toxicity from using these in combination. Though more recently, the development of antibody drug conjugates has sort of brought pneumonitis, I think, back to the forefront because there were increased rates in the phase 2 and phase 3 clinical trials of these drugs. I wanted to highlight just trastuzumab deruxtecan specifically, which I'm sure you're more familiar with than me, in that this is an antibody drug conjugate linked to topoisomerase inhibitor with this cleavable linker, which allows it to sort of target neighboring tumor cells. It's in the DESTINY-Breast1 trial showed significant benefit in terms of treatment response, though when we review lung toxicities and just highlighting here the different grades, sort of from grade 1 asymptomatic just on imaging to grade 5 being sort of life-threatening toxicity. In the DESTINY-Breast trial 1, 25 patients or 13% experienced some form of ILD, and a few cases of severe fatal reports were noted. So obviously a concern. And the fact that grade 2 and grade 3 toxicity were sort of the most common, suggesting patients were symptomatic and likely needed treatment, is something to note. And then more recently, the DESTINY-Breast3 trial, which I'm sure people saw was published last month in the New England Journal, showed improvement with trastuzumab deruxtecan compared to trastuzumab emtansine in terms of progression-free survival and overall survival. And when we looked at the side effects from that treatment, ILD was still identified in the deruxtecan group, 10.5%. Thankfully, no life-threatening events, though a fair bit of grade 2 and several grade 3 events, so something to note. With respect to the pathogenesis or pathophysiology of this toxicity, they've done some interesting studies looking at injecting the antibody drug conjugate or just the payload. And when the topoisomerase inhibitors injected into the bloodstream in animal models doesn't seem to result in drug toxicity. It seems to be more of a target-independent toxicity where the antibody drug conjugate have been localized on histopathologic evaluation of ILD within the alveolar spaces and alveolar macrophages. The HER2 receptor is really only localized to the bronchial epithelium, where that was not sort of the centered area of toxicity. So that's sort of the current thought about how this drug toxicity occurs. And so just going back to our case, a reminder that patient's CT scan showed a pattern suggestive of a non-IPF diagnosis, more in keeping with an organizing pneumonia or NSIP type pattern. The patient did have a bronchoscopy, which showed an elevated lymphocyte count at 33%, elevated eosinophils as well. There was no evidence of infection. And so this was thought to be consistent with inflammatory ILD with an organizing pneumonia or NSIP type pattern. Because of their joint pains and serology, they were evaluated by rheumatology and thought to have an underlying disease sort of akin to a dermatomyositis type of phenotype. They were treated with prednisone and continued on their trastuzumab. Unfortunately, they developed worsening shortness of breath and infiltrates on steroids and were hospitalized. And as a result, there was a thought that their disease still may be in some way provoked by their underlying chemotherapy. And so this was discontinued. So a little bit about treatment of anti-neoplastic related toxicities. And I will say that there's not one sort of unifying correct approach. I think there's a number of recommended approaches in the literature, but really the treatment seems to be focused on what is the class of medication, and is there data specifically looking at that class of medication? How sick is the patient, and what are the risks of recurrence? And this table comes from a review of immunotherapy-related ILD treatment, where, in that sort of grouping of medications, they say grade 1 disease you can consider holding or treating through, depending on the severity of the imaging, really, and that re-challenging if drugs are held is reasonable. For grade 2, the drugs are typically stopped and treatment is usually suggested, but re-challenging is generally considered. Whereas for people with more severe reactions, the sicker they are, the higher the steroids tend to be, and certainly re-challenging is avoided in those severe reactions. Now, the data regarding how to manage patients with severe reactions, refractory to first-line treatments, is very poor. There are, guidelines, oncology guidelines suggesting doses of steroids, up to 4 milligrams per kilo, though I think practically speaking, these patients will often get pulsed with the 500 to a gram of solumedrol. And then if they're not responding, consideration of additional agents, and they sort of qualify not responding to within 48 hours, which is pretty rapid. But people who are not improving, considering adding other agents such as infliximab, mycophenolate, cyclophosphamide. I will say the data for the use of all of these medications is very poor. Some of them don't really make sense to me clinically. Mycophenolate takes months to start to work, so it doesn't make sense to use in the context of critically ill hospitalized patients. Infliximab, my understanding, it's been shown to be beneficial in gastrointestinal related toxicities from immunotherapy, but the data that it helps lung toxicity is non-existent. Cyclophosphamide, certainly a toxic medication resulting in severe immunosuppression, certainly something that we use, but would need to be used cautiously. I would argue that in reviewing more recent observational studies, that something like intravenous immunoglobulin may be a better approach. Certainly, it's something that is available and will usually start to work within a couple of weeks, days to weeks. It is not associated with immune suppressive effects and does have immunomodulatory properties. The available observational studies would suggest that they tend to do better when they receive IVIG than when they receive other immunosuppressing agents, though it's generally small series. And specifically talking about trastuzumab deruxtecan, because these new antibody drug conjugates, the approach that's been recommended is actually quite different than immunotherapy, in that for patients with grade 1 disease, so asymptomatic isolated imaging findings, it's suggested that the drug be held and corticosteroids be provided or strongly considered, which is a bit more aggressive than the immunotherapy related management. And that for patients with grade 2 disease, the drug not be considered in terms of re-challenging and it be discontinued. So this sort of requires a bit of a different approach and a lower threshold for treatment. And so in our case, the patient did receive pulse dose steroids when they were hospitalized and were experiencing grade 3 toxicity. They were then transitioned to steroids and tapered down. They did receive IVIG as a steroid sparing agent, primarily because of the concerns about their underlying inflammatory connective tissue disease, as well as their underlying malignancy. And they've continued to have stable but severe disease. The hope is that we can at least maintain their current lung function and prevent any progression. And so I just wanted to highlight, the fact that we at Sunnybrook try to see these patients quickly. Dr. Rajkot and I work in what's called the TRAP clinic, as you may be aware, the Treatment of Respiratory and Pleural Problems clinic, where we see only patients in Odette that are referred for lung issues. it's not restricted to lung toxicity for medications, but certainly that's a common referral that we see. We certainly try to see patients within a couple of weeks and organize timely investigations and bronchoscopy when it's needed. And I think this really does, the management of these patients really does require a coordinated approach between multiple disciplines, oncology, respirology, and radiology. Specifically, you know, if you can have dedicated imaging spots, that is valuable to make sure that we can get patients evaluated quickly. And so just to summarize, if I didn't make it clear, that interstitial lung disease is the most common form of drug-related lung toxicity, and anti-neoplastic treatments are the most common group of medications associated with this. And that the details of each patient's presentation are important because each has a unique rate of lung toxicity, and you have to consider the individual risks for the patient, and it requires a nuanced evaluation. And that when we recognize these patients and evaluate them quickly, you know, we can usually prevent toxicities, or hopefully at least prevent severe reactions, and maybe even allow them to continue on treatment in the future. So with that, I'll just stop here. I was asked to share this slide if people wanted to provide feedback, and I'll see if there's any questions.
Thank you so much, Lee, for that excellent and comprehensive overview. I certainly learned a lot and takes me back to my Royal College studying days in respirology. And obviously it's clear that it's a very complicated assessment. When we refer people for ILD assessment, maybe I'll just pause and ask if anybody else from the audience has a question. If not, I'll have one that I'd like to ask.
Hi, Lee. Can you guys hear me?
Yeah.
Can you guys hear me? Sorry, my camera's not working in clinic. Thank you for that. That was excellent. I had a question specifically for TDXD. What are your thoughts on the management protocol in terms of the grade 1 toxicity? I know that that's kind of driven by the trials, but I know from a practical perspective and kind of as we're seeing more patients on this, I guess we're getting a sense of, you know, is this practical? Does it matter? How do we layer this with their staging? How do we kind of get them to you quick enough? I mean, I know this is an evolving discussion that we're not going to do in 6 minutes, but could you maybe give us a quick update as to what this sort of respirologist kind of perspective on this particular drug is? Because as you've highlighted, it's quite different than what we do with other drugs.
Yeah, and I think the answer is, I don't think people know. I think if you ask my colleagues in respirology what this drug is, they're going to tell you they've never heard of this medication. And I think that's because, and again, correct me if I'm wrong, it's only been approved by Health Canada for sort of third-line treatment of HER2 breast cancer since June. And I personally have not even seen a patient on this medication. And so I think I'm familiar with it, and I've read the trials because of my sort of involvement in the oncology clinics and sort of collaborating with others on anticipating this concerning sort of rate of adverse events. But I think if you asked other respirologists, they're going to say, I've never even heard of this medication. So I think the first step is at least sort of getting some awareness that, and you know, is this something that we're going to see, and is it something that is going to be used more widely? And I think especially given from what I've seen with phase 2 trials with benefits among non-small cell lung cancer, gastric cancer, uroepithelial cancers, if this is something that provides significant clinical benefit for patients, we're going to start seeing a large volume of them receiving this treatment. And as a result, even if it's the rates are generally low, if toxicities can be severe, they're going to come to us because the volume's high. I think what do I think about the suggested protocols? I think that it's difficult. We need to kind of find a balance between ensuring patient safety and evaluation, but also it needs to be somewhat pragmatic. You know, we can't, I suspect, do CT scans every 6 weeks like they were doing in the protocols for the clinical trials. We just don't, I imagine, have the access to do that in all of these patients. I worry that the grade 1 toxicities that were identified if we aren't monitoring as closely as they were in real world practice, it may end up being grade 2s and grade 3s and grade 4s because you're not detecting them soon enough to stop drug. And I also find it challenging as a clinician to not adhere to recommended approaches for management of toxicities that are outlined in product monographs, because if this is what's recommended by the manufacturer, how can I really go against those strategies, right? So I think my approach will be what is recommended, because otherwise it might be a bit cavalier until we have more real world data about rates and management strategies. And so I think we need to take it seriously. And I imagine that we should have some protocols in place, CT scans every 3 months, which is probably close to what's going to happen anyway in their cancer care. Maybe baseline PFTs, though the pandemic has made it challenging to get PFTs even for our chronic lung disease patients without background disease, but maybe baseline is something that we should target. And monitoring for signs and symptoms very closely, and certain rapid assessments of CT imaging if symptoms are developing, because that we want to try to prevent severe reactions and keep people on effective medications. Sorry, that's a long-winded answer to that question, but I hope that answers things.
That was very good answer. Thank you. Actually, that happens to be my my question as well, Sonal, about that grade 1 monitoring, because certainly doing 6-week CTs may be challenging. And Lee, we will be seeing more and more patients on this drug because it has been shown to be better than standard second-line therapy for HER2-positive breast cancer. So we'll be seeing it move into the second-line setting and being used more and more. We have a limited time. We have 2 more minutes, but maybe I'll pause to see if anybody else has a question.
Yeah, I see Andrea asked about how to get PFTs. So right now, PFTs, because the pandemic has made it so hard to get PFTs, they've really been restricted to ordering by Respirology. We stopped accepting PFT requests from outside physicians, outside the hospitals. We do get preoperative PFTs from surgeons, because that's a quality metric to get timely surgeries for patients. But I think what we'll try to do is, if we see if we have capacity for this, that we try to get baseline PFTs for patients quickly, and we may have to create a protocol to try to get baseline testing at least for these individuals.
Good question. Thank you. And thank you for that answer, and for your talk again, Lee. That was excellent. I also like to say thank you to Catherine Simos, who helped to organize this event, and Antoinette, as usual, and also to Pfizer for sponsoring the event. I think Andrea has one more question. Should we refer to the TRAP clinic for now?
Yeah, there are paper requisitions for PFTs. I imagine you can just fax them through. And I'll have to chat with Dr. Tandon and Allison from the PFT lab to say if we should just, rather than delaying things, because I don't want to delay people for assessments before we can even start the process for PFTs. So we may have to come up with a streamlined protocol. For now, certainly a referral is probably the way to go until we create a pathway. But there are paper recs that you can send to the PFT lab to try to coordinate. And if we're running into barriers, then we may have to fix that.
Okay, great. Well, thank you one more time. And I guess we'll call it a session, because it's 1 o'clock. So okay. Take care, everyone. Have a good afternoon.